ER doctors, cardiologists, and cardiac surgeons all know well that the diagnosis of acute aortic dissection can be extremely difficult. I teach the residents that if a patient has convincing chest pain that sounds like an acute coronary syndrome, but the ECG is normal, think of dissection. But that is painting with a very broad brush. To help in this difficult clinical scenario, in 2010, the American Heart Association and ACC released guidelines for the diagnosis and management of patients with thoracic aortic disease, which identified high-risk clinical features to assist in the early detection of acute aortic dissection. 3 features of a patient on presentation were assessed: presence of a high-risk condition, of course, such as Marfan's or a family history, high-risk pain features, for example, tearing pain, and a high-risk exam feature. Now in circulation, the sensitivity of these risk markers has been validated. To do this, the researchers examined patients enrolled in the International Registry of Acute Aortic Dissection for 14 years. And an aortic dissection detection risk score of 0 to 3 was calculated on the basis of a number of risk categories in which patients met criteria. With the use of the risk score, 4.3% of patients in the registry were identified as low risk, 36.5% were identified as intermediate risk with a score of 1, and 59.2% were high risk with a score of 2 or 3. The researchers concluded that the clinical risk markers proposed in the 2010 Thoracic Aortic Disease Guidelines and their application as part of a risk score comprise a highly sensitive clinical tool for the detection of acute aortic dissection. I'm Peter Block with a CardioSource Heart Minute.